Good morning, everybody. I'd like to thank the organizing committee, Professor Rosano, for the kind invitation. So in a couple of minutes, I'm going to cover the imaging for the management of patients with chronic coronary syndrome according to the last ESC guidelines. Patients having chest pain, if this is coronary artery disease or not, how can we know what is the investigations that should be done to rule in or rule out coronary artery disease? This is my disclosure. And we know that the initial diagnostic management of patients with angina and suspected coronary artery disease should pass in different steps. So first of all, proper history taking and clinical evaluation to assess symptoms and signs. We have to assess for comorbidities and other causes of symptoms. We have to do the basic testing for every patient. And the most important thing is to assess the pre-test probability and the clinical likelihood of coronary artery disease, because this will detect which is important investigations needed for these patients. And finally, according to the risk evaluation for the patients, the appropriate therapeutic strategy will be designed. So the guidelines included the 6 clinical scenarios in patients having probability of coronary artery disease: patients with suspected ischemic heart disease, patients with heart failure or LV systolic dysfunction, stable symptoms after acute coronary syndrome or revascularization, which might be less than 1 year or more than 1 year, suspected microvascular disease or vasospasm, which will be discussed in details in the next presentation, and finally, asymptomatic population screened to detect underlying ischemic heart disease. So it's important to look what's behind the symptoms of the patient. If this is something benign or it is something serious, patients having left main disease or multi-vessel disease. So the initial diagnosis and the management, as I said, that started by assessment of symptoms and signs according to the history, because patients who have crescendo angina or unstable angina should be treated according to the ACS guidelines. Comorbidities will identify patients who is a candidate for revascularization, and resting ECG, which can rule out ischemic changes, biochemistry, chest X-ray, echocardiography, pre-test the probability according to the likelihood of coronary artery disease, which I'm going to discuss it now, because a very low likelihood of coronary artery disease can indicate that there is no need to do further investigations. While if the high probability, so we should go to more diagnostic strategy, like very high risk patients in which the pre-test probability is very high, so invasive strategy from the start is needed. And after risk stratification, the treatment strategy, medical treatment or revascularization. For comorbidities like obesity, non-cardiac vascular disease, comorbidities like different CKD, arrhythmias, quality of life, valvular heart disease, all these comorbidities should be identified. Then go to the investigations, starting with the basic laboratory and biochemical tests, kidney functions, rule out diabetes, resting ECG, and the possible ambulatory 24-hour ECG monitoring in patients who have suspected arrhythmias as well. Then resting echocardiography, which is important to assess both systolic as well as diastolic function, and to assess for the presence of resting regional motion abnormalities, or to rule out other cause for angina, like aortic stenosis or hypertrophic cardiomyopathy. Chest X-ray is a class 1C recommendation in patients with atypical presentation, signs and symptoms of heart failure, or a suspicious of pulmonary disease. According to this slide, we can appreciate that the pre-test probability depends on symptoms, typical or atypical angina or shortness of breath, men or women, and according to the age. So if you look, for example, for a 70-year-old male patient have typical angina, so the pre-test probability is high compared with, for example, in women who have atypical angina, the pretest probability is low. So if we have a pretest probability more than 15%, this indicates the need to do investigations, non-invasive and invasive. But if the pretest probability is very low, less than 5%, for example, we don't need to do investigations for coronary artery disease. In between 5 to 15, you might need to do some investigations. So again, very low risk for coronary artery disease, a pretest probability, and the likelihood of coronary artery disease, if it's much lower, less than 5%, no need for investigations. And in between the very high risk probability, we need to do investigations. The investigations depends on the patient characteristics, the patient preference, the availability of the imaging tool, as well as the local expertise available to do this test, which should be of high sensitivity and specificity value to diagnose coronary artery disease. So again, a very low probability, forget it as coronary artery disease, and for very high probability, the negative predictive value is much lower, and those patients should be treated as coronary artery disease. And in between, we need some investigations like coronary CT, coronary angiography, or non-invasive imaging. So the guidelines specified that non-invasive functional imaging for myocardial ischemia or coronary CT angiography is recommended as the initial test to diagnose coronary artery disease in symptomatic patients in whom obstructive coronary artery disease cannot be excluded by clinical assessment. And this is class 1B recommendation. The selection of the initial invasive diagnosis test is based on the clinical likelihood of coronary artery disease and other patient characteristics, which according to the availability, the cost, the local expertise. Invasive angiography, doing coronary angiography class 1B in patients as an alternative to other investigations if patients have severe symptoms refractory to medical therapy. The other non-invasive investigations indicating a high-risk patients, like, for example, SPECT with an ischemic myocardium more than 10%. Risk assessment is very important, and this should be done. According to the guidelines, risk stratification is recommended based on the clinical assessment as well as the result of the diagnostic test. Also, risk stratification should be done using stress imaging, coronary CT angiography, or according to the exercise test if patients is able to do an exercise. And in symptomatic patients with a high-risk clinical profile, invasive coronary angiography complemented by invasive physiologic guidance, estimation of IFR, FFR in the cath lab for borderline lesions to assess the hemodynamic significance of this coronary artery disease, which is class 1A recommendation. Again, risk assessment, class 1A to do invasive coronary angiography complemented by invasive physiologic guidance, FFR, IFR, in high-risk patients when revascularization is considered. And also, coronary angiography is class 2A in patients who have an inconclusive or conflicting results from non-invasive imaging. So what is the non-invasive functional imaging for myocardial ischemia? What is the ideal non-invasive imaging technique? Because this is important, it should be able to provide information on both coronary anatomy as well as the functional consequences of coronary lesion, because it will aid in diagnosis and risk stratification, and finally guide the decision for optimal revascularization. So we have, for example, stress echo, which is well-known non-invasive test to rule out coronary artery disease. It has a good sensitivity and specificity for diagnosis of suspected coronary artery disease to identify regional motion abnormalities, and it can identify reversible and irreversible wall motion, can differentiate between ischemia as well compared with a scar due to previous infarction. And recently, tissue Doppler, strain imaging, speckle tracking have shown also promising for objective quantification of regional motion abnormalities by stress echo. On the other hand, the nuclear studies, myocardial perfusion imaging, SPECT perfusion, provides more sensitive and specific prediction of the presence of coronary artery disease with good sensitivity and specificity, and also can differentiate between reversible and irreversible coronary artery disease. Patients who sustained an infarction with a scar in which there is no benefit of revascularization, and patients with active ischemia. And according to the perfusion defect, we can stratify the risk of these patients if it's a high-risk patient or not. So according to this slide, which shows these different segments analyzed in the myocardial perfusion imaging with different images, if we have a small defect in one or two segments, this indicates the myocardial ischemia less than 10%, while at 10 to 20% in 2 or 3 segments indicate a medium risk. The high-risk patients who have a large area of reversible ischemia, more than 20%, which indicate a high-risk patient. Recently, cardiac magnetic resonance imaging has a role also in diagnosis of coronary artery disease in patients who are unable to perform echocardiography, and it can assess also the LV volumes, the ejection fraction, the presence or absence of myocardial ischemia. So it's considered as a complementary non-invasive test in imaging for coronary artery disease patients. If we did all these investigations, so who is the highest risk patients? The highest risk patients, if we did treadmill exercise ECG, and we have a high Duke treadmill score, for example, patients who have angina at very low workload with early SC segment depression, this indicates a high risk patients in which the cardiovascular mortality is more than 3% per year. If we did a SPECT, if we have an area of ischemia more than 10% of the LV myocardium, this indicates high-risk patients. By stress echo, 3 segments or more with the stress-induced hypokinesia or akinesia. CMR, 2 out of 16 segments with a stress perfusion defect, or 3 or more dopamine-induced dysfunctional segments by CMR, and by coronary angiography, patients who have left main disease, 3-vessel disease, or proximal LAD, those patients are at high risk. And finally, in the cath lab, if we have an FFR for a lesion and it's less than 0.8, IFR less than 0.89, this indicates also high risk. So according to this slide, we can identify which test is needed for which patient to diagnose coronary artery disease, as well as to risk stratify for high-risk patients or low-risk patients. The guidelines recommended that revascularization is needed for prognosis in patients who have significant left main disease, more than 50%, patients with proximal LAD, more than 50%, 2 or 3 vessel disease, more than 50%, with impaired LV systolic function, ejection fraction less than 35%, large area of ischemia, more than 10% of the LV myocardium, and single remaining patent coronary artery stenosis, more than 50%. For symptoms, which is the other important target in treating patients with coronary artery disease, is to improve survival and to improve symptoms. So hemodynamically significant coronary stenosis in the presence of angina not responding to medical treatment, so those patients should be considered for revascularization. This is an interesting study which was published 1 year ago, comparing CT coronary angiography with invasive coronary angiography in more than 3,600 patients. Is it initial CT coronary angiography or invasive coronary angiography is of importance for the outcome? And they did not demonstrate a difference in the primary endpoint in terms of cardiovascular death, non-fatal MI, non-fatal stroke, between invasive coronary angiography and CT coronary angiography. However, the complications, of course, was high, 1.9% compared with 0.5% with invasive coronary angiography compared with CT coronary angiography. So you can appreciate here the CT coronary angiography which can identify a proximal LED lesion, and anatomically by coronary angiography, it is the same proximal significant LED lesion. And here, the dual modality of adding another modality for CT coronary angiography to assess for the hemodynamic significance of a lesion, FFR, if it is less than 0.8, this indicates a hemodynamically significant coronary lesion. The last ESC 2019 guidelines for management of chronic coronary syndrome, if the patient has angina and the documented ischemia with multivessel disease, those patients should be considered for revascularization. And in the absence of ischemia, if it is if associated with a significant lesion more than 90%, or FFR less than 0.8, IFR less than 0.9, or ejection fraction less than 35%, so revascularization should be considered. If there is no angina and there is the evidence of documented ischemia, if it is large area of ischemia more than 10%, then revascularization should be considered. However, after ischemia trial, we have a lot of debates about when to send the patients for revascularization. Is it optimal medical treatment alone is sufficient, or optimal medical treatment with invasive strategy? And in the absence of ischemia, the same indications, hemodynamically significant lesion, more than 90%, in the cath lab if we have FFR significant or IFR. Finally, we have to choose the appropriate strategy of treatment, optimal medical treatment or revascularization. So, ladies and gentlemen, the take-home message for management and imaging modalities for patients with coronary artery disease: imaging is useful to confirm the diagnosis of coronary artery disease in patients with intermediate pretest likelihood of the disease. Choice of the proper imaging modality should depend on expertise, availability, and importantly, clinical likelihood and pretest probability. CT coronary angiography can reliably rule out the presence of obstructive coronary artery disease in the presence of low to intermediate pretest likelihood, and the combined and the hybrid imaging with anatomical and functional imaging modalities is attractive for comprehensive evaluation of anatomy and the functional significance of coronary stenosis. Thank you for attention. This is my institution, and that it's an honor that Sir Yaqub was graduated from the same institution. Thank you for your attention.